committees.
And you can have it all with your membership in the Greater Bakersfield Chamber of Commerce.
This is Strictly Business, presented by the Greater Bakersfield Chamber of Commerce. Sponsored in part by the law offices of Young Wooldridge, San Joaquin Community Hospital.
And welcome back to Strictly Business. Joining me now are Doctors Levi Dansby and Russell Paul. They're interventional radiologists at Quest Imaging, and they're here to chat about a new minimally invasive procedure and the impact it has on local patients. Good morning, gentlemen.
Good morning.
Good morning.
Thanks for having us.
What is an interventional radiologist, first of all?
All right, well, an interventional radiologist is someone who uses imaging, guidance, fluoroscopy, CT scan, and basically can do procedures through mostly needle punctures or only without making any incisions or anything like that. So,
Okay.
yeah.
So let's talk about, it's TACE, TACE. So what does that stand for, and what is this procedure?
TACE stands for Transarterial chemoembolization. And what it is, it's
I'm glad you said that and not me, yeah.
So what it is, it's a treatment for liver cancer.
Okay.
What we do is, similar to cardiologists, we make a puncture in the vessel in the groin. We go up with special catheters, and once we're happy with where we are, we deliver special beads that have chemotherapy. And what the beads do over time is they leach the chemotherapy into the tumor. So we're cutting off blood supply and we're delivering chemotherapy to the tumor itself.
Oh, wow. Okay. And is San Joaquin Community Hospital the first hospital in Kern County to offer this new treatment?
To our knowledge, it is the first hospital
Okay.
to offer this to the county, yes.
Yeah, and it's TACE is sort of part of a more comprehensive program that the hospital is offering in support of our cancer center, where the minimally invasive techniques include TACE, percutaneous ablation, and TheraSphere, which are radioactive beads that we administer.
So the percutaneous ablation is actually something where we make a very tiny nick in the skin and we go through with special probes that we either fry or we freeze the tumor to kill it. And in certain tumor selection criteria, it's actually equivalent to surgery depending on the tumor size.
Okay.
For example, like kidney cancers would be one of them.
So would the side effects then from the chemo be less less impactful to the patient, I should say?
Yes,
Absolutely.
yes. So because it's selective and it's focal, you don't get the side effects that intravenous systemic chemotherapy can cause.
Oh, wow.
And there's actually papers that look at that where they've drawn blood, peripherally through an IV, and they see that the amount of chemotherapy is not the same as when someone gets traditional chemo, where they just basically start an IV and give it systemically. So we've seen that patients actually have less hair loss, less fatigue, that sort of things compared to traditional chemo.
Okay. So before this was available in Bakersfield, where did you have to go to get this done?
Patients in this area, I think, tend to go down south. UCLA, Cedars-Sinai, USC. I think there's some areas up north that, well, of course, depending on how far north you want to go.
Sure.
Obviously, San Francisco and Stanford and places like that offer it. But I think the closest was in LA.
Okay.
Yeah.
So other than having the ability to just stay here in town and have this treatment, what other benefits do we see from the TACE?
Well, I think it's huge for the patient and also the patient's family because they're able to coordinate care here locally.
Mm-hmm.
It's a big financial burden for patients to have to go down to LA, have to spend for hotels, and also it could be a multiple day visit, by the time they do their consult and their therapy. Whereas when patients can stay locally, we find that the patient's family is actually more involved as well because they're able to attend the appointments. They have more input. They can ask their questions as well before we take the patients to the procedure. The other great thing is that we actually have a tumor board. So all of our procedures before we actually, perform the procedure, they're presented before a multidisciplinary board where we have all these different specialists that have their input as far as whether or not we're doing the right thing for the patient, either A, surgery, B, transplant, or C, our procedures.
Okay.
So.
So you mentioned financially the cost of hotels and that sort of thing, traveling. So what does this mean typically? Is this something that most insurances cover? Is this considered elective? Is this...
No,
It is covered.
Insurance
yes.
covers.
Yes.
Yeah, covers
But
this,
but
yeah.
one of the things I think that I'd have to say is it might create difficulty for patients having to go out of network. Like, for example, down to LA to get the procedure. So I think while they may eventually get it covered, I think they find that's probably a bigger hurdle than staying locally.
Okay. So typically with a more intravenous chemotherapy, you'll have a regimen of a certain amount of time and a certain number of treatments. With this, is it are you finding that the treatment time is shorter?
So the treatment
In most cases.
the actual treatment time is basically the day of the procedure, and then the impact carries out from there. And what ends up happening is that you'll monitor the patients for life, and you'll shrink tumors, and depending on, like in cirrhotic patients, they have a predisposition to developing tumors. So you'll shrink a tumor, and because they're cirrhotic, they may develop another tumor. So you'll continue to monitor them and treat tumors as they come up. The limiting factor is the impact on the liver function, and so we have to kind of balance that. But basically, it's a lifelong treatment. But the actual procedure doesn't take long. It's just the day that we do the procedure. And that's
It
about
usually lasts about an hour or two. And the ultimate goal of the treatment is actually to get the patient to liver transplant. That's the curative therapy for primary liver cancer. What our procedure allows is the patient to actually stay within criteria for years on end, or sometimes we can actually downstage someone, take someone who is not a liver transplant candidate. If we treat them and we can shrink the tumor enough, then they can qualify for the liver transplant list. So that's exactly what our goal is, to get these patients to liver transplant, because that's the ultimate cure.
Okay. And when you say qualifying them for liver transplants, is this a years-long waiting list at times?
Absolutely. So
Yeah,
it's
it
by
can be.
region, and the average wait time in our region is about 8 months to a year, which is why it's so important that these patients get treatment in the meantime, because if not, as tumors tend to do, they grow. And if they grow too big, now you're off the list. You're not a candidate anymore.
Okay. So what's the success rate? How have you, what kind of early successes have you seen with this program? What kind of outcomes?
we've done about 4 procedures in 3 patients, and the short-term outcomes have been good. There have been regression in tumor size, or you can measure response in terms of arresting growth so that it'll stay the same, or if you're lucky, you'll get some shrinkage of the tumor. And we've seen that in our patients. Long-term outcomes are still a little early to talk about that, but we expect that these patients will do really well. We had we talked about how sometimes you have to balance the impact of doing the procedure and the side effects with how much liver function, baseline liver function the patient has. In one patient, we had tumors in both sides of the liver, and so we treated one, and the other one we had to wait so that we wouldn't overwhelm the liver from the treatment. And in the interim, the treated tumor shrunk a little bit, and the untreated tumor grew, and then we brought the patient back and we treated that tumor. So,
Okay.
yeah.
Is this something that could lead or has already led to changes in the way cancer is treated across the board, not just with the liver?
Oh, absolutely. Like I would say nationally, where I trained last year at Northwestern, interventional radiologists are now a mainstay at Tumor Board, because our treatments are very, they're viable options for patients who are otherwise, a lot of times patients are too sick to undergo surgical resection, which tends to happen when patients are cirrhotic. So as far as the way, the treatment is handled, absolutely, because we're now a viable option for these patients in their treatment pathways. So that's why, again, our tumor board is so important, because we sit next to surgeons, to medical oncologists, radiation oncologists, and us, and we're all in the same room discussing the patient's treatment, and really we do what's best for the patient, so that way we can all have a game plan and all agree on what should be done. So, and I think that's the best approach. I trained in academics, and so did Dr. Paul. So that's the way we did it there, and that's what we're bringing to the town here.
Okay. So while this particular procedure is strictly focused on the liver, we may be seeing or are seeing other similar treatments for cancers in other parts of the body.
Absolutely,
100%, yeah.
absolutely. You'll have bone tumors which metastasize from various sites, colorectal cancer that metastasizes to the liver, renal tumors, and the three modalities we talked about, the TheraSphere, which is the radioactive bead, the percutaneous ablation, and the TACE procedure. Those combined offer a nice, comprehensive, minimally invasive or non-surgical palette for us to draw from in treating patients.
Right now, things are early on, but they're actually looking in and doing data trials on lung cancer. So patients that aren't necessarily, candidates for lung resection, they're looking into using the same modality, this TACE, in the lung cancer population. So if that turns out to be, fruitful, that would be huge for these patients. So, and it's something that we'll be seeing in the next few years come out.
Okay. And you mentioned that the side effects are not quite as strong as they would have been with a traditional chemotherapy. But just for those that aren't real familiar with that, what would the typical side effects look like?
So with TACE in particular, there is what we call post-embolization syndrome. So anytime you cut off the blood supply to a particular organ, that part of the organ will undergo cell death, and in response to that, you'll get inflammation, and that can cause a lot of pain. So typically, the post-embolization syndrome consists of pain within the liver or the right side of the abdomen, nausea, vomiting, some fatigue. It starts as soon as the procedure is over, usually peaks around 48 to 72 hours, and then begins to dissipate thereafter. But again, other than that, the other side effects that you may feel, like the long-lasting general fatigue or hair loss, as Dr. Dansby was saying, you won't see those things, or typically don't see those things with TACE.
And the difference is with traditional chemotherapy, you come in for multiple cycles, so you're talking about weeks of treatment. So for weeks to months, you feel fatigued, right. You get hair loss, that sort of thing, where our treatment is local. So this is something that you get the post-embolization syndrome, you have pain for a few days. We manage that with medications to take care of those side effects that are known. But usually by the end of the week, the vast majority of people are back to normal, feeling pretty well. So that's the difference between that and traditional chemotherapy.
So let's shift gears for a bit. What other types of procedures and imaging technologies does Quest offer here in Bakersfield?
Related to
cancer treatment.
To cancer treatments. Okay. Well, like we said, we didn't go in depth to it, but TheraSphere, what we were talking about, is where you actually have glass beads that are impregnated with a radioactive isotope, and it's a very short distance, like within a centimeter, and we infuse these beads into a tumor. It's similar to TACE in terms of the technique. You infuse these radioactive beads into a tumor, and they blast the tumor with this radioactivity, and it kills the tumor. And it's good in the sense that it causes even less side effects than TACE, because it doesn't really cut off the blood supply. The primary mode and how it works is the radiation, and it's also nonspecific in terms of it'll work on any kind of cancer with the radiation. And so that's one of the modalities that we're going to be offering and ramping up here. And both Dr. Dansby and I were proctored and trained by Dr. Riyadh Salem, who is at Northwestern University, in this technique. Yeah.
And the other ones, like we mentioned before, would be the percutaneous approaches. Cryoablation is actually just a fancy way of saying freeze the tumor, and that's primarily used for kidney cancers. And the other modality we'll be offering is microwave ablation, which is usually done in liver cancers, and that has to do with selection criteria for the tumor. If the tumor is small enough, a percutaneous approach is preferable because it's been shown to be equivalent to surgery for a 5-year disease recurrence or progression, as long as the patient selection is similar. So those are other things that are in the pipeline. Now, as far as the other oncology things, we offer the full realm of oncology imaging. We do PET, we do whole body PET. We also have a women's imaging center that's downtown with the Cancer Center, where we do all the modalities for breast as well. We have a fellowship-trained radiologist and mammography, which I think has been a very big thing to the group. So.
Okay. Well, gentlemen, thank you very much for coming in. Dr. Dansby, Dr. Paul, thank you for taking your time this morning to come and tell us about these exciting new treatments. And certainly we hope that it continues to be a great benefit for all the patients here in Bakersfield. So thank you very much for coming in.
Thanks
for having us.
us.
Appreciate it.
All right. We're going to take a break, and we'll be back with more Strictly Business and the closing bell.
If your doctor